Hi students, now we are going to discuss delayed puberty. Let's see how delayed puberty is defined. So, absence of secondary sexual characteristics by 13 to 14 years of age, or the absence of menarche by 15 years of age. These two time frames are very important. So, if there's a girl who doesn't have menarche by 15 years of age, straight away she goes into delayed puberty. Lots of questions are asked on this topic. So a typical question would be, when is puberty considered to be delayed in girls? Absence of menstruation by 14 years, or secondary sexual characters by 14 years, or absence of menstruation by 15 years, or absence of secondary sexual characters by 12 years. So, these kind of confusing questions would be put forward, different ages. And yes, the answer would be absence of menstruation by 15 years. This is one of the most common questions which I've seen on this topic. Alright, so let's come to the causes of delayed puberty. Back to our HPO axis, hypothalamic pituitary gradient axis. So we have the hypothalamus, which secretes gonadotropin releasing hormones, which go and stimulate the anterior pituitary to release FSH and LH. FSH stimulates the ovaries to produce estrogen. Luteinizing hormone appears, there is ovulation, and finally secretion of progesterone. Finally, one fine day, we have no estrogen, no progesterone, and this is manifested as menstruation. Now, the causes could be why puberty is delayed. So, back to the previous slide. The causes could be anything around this hypothalamic pituitary ovarian axis. So, let's say the hypothalamus is not secreting GnRH. When there will be no GnRH, obviously, this HPO axis will not progress forwards, and we will have this HPO axis disrupted at this stage. There will be delayed puberty. Or let's say hypothalamus is definitely secreting gonadotropin releasing hormones. What this GnRH should do is that it should stimulate the anterior pituitary, and now the anterior pituitary should secrete FSH and LH. Let's say the problem is not at the level of hypothalamus, which is secreting GnRH, but it is the anterior pituitary. Despite stimulation, this anterior pituitary is not releasing gonadotropin, FSH and LH. So again, the HPO axis will break, and there will be nothing further beyond this stage. This is known as hypogonadotropic hypogonadism. Why? Because, going back to the slide, so what you find is that estrogen is low, progesterone is low. Why is this estrogen progesterone low? This estrogen progesterone, which should be here, secreted by the ovary, is low because this ovary is not getting any signal by FSH and LH, right? So the problem is because of some problem with the GnRH, some problem with the gonadotropin. This is known as hypogonadotropic hypogonadism, wherein the cause lies with either the hypothalamus or the pituitary. The most important reasons for hypogonadotropic hypogonadism would be constitutional delay. There is some chronic illness, malnutrition, or there is a condition which is known as Kallmann syndrome, and we will be discussing Kallmann syndrome, which is isolated gonadotropin deficiency. Or there can be some intracranial lesions like craniopharyngioma, pituitary adenoma, some problem with the hypothalamus or pituitary. It could be an absent pituitary. It could be a pituitary which is not working nicely because it's being compressed by a tumor, which is resulting in problems with the working of pituitary. So, we do find hypogonadism. Hypogonadism means estrogen is low, progesterone is low. Why is estrogen and progesterone low? This is because there is some problem with hypothalamus or some problem with the GnRH, which is hypothalamus is secreting, some problem with the anterior pituitary or the gonadotropins that it is secreting. This is known as hypogonadotropic hypogonadism. Next, we can have another type of hypogonadism where yes, estrogen is low, progesterone is also low. But the problem is nothing to do with hypothalamus and pituitary. So hypothalamus, yes, it is releasing gonadotropin releasing hormones. GnRH is present, pituitary is present, pituitary is getting stimulated, pituitary is producing FSH and LH. However, there is some problem with the ovaries. Problem at this level. And so these ovaries, they are not producing estrogen and progesterone. This type of hypogonadism is known as hypergonadotropic hypogonadism. You find why hyper? Because hypergonadotropic, because there is so much of FSH and LH which are going and trying to stimulate the ovaries, but because there's some problem with the ovaries, so the ovaries are not producing any estrogen or progesterone. Why does this happen? Maybe we have removed the ovaries, as in oophorectomy has been done. Maybe some radiation damage has been done to the ovary. Maybe this is a patient of Turner syndrome or something which we know as gonadal dysgenesis. Or it could be just figure. These are the things that we are going to discuss in the further slides. Or there could be condition wherein estrogen is normal, progesterone is also normal, and still there is no menstruation. So this condition is known as eugonadism. तो हम ये देख रहे हैं कि ओवरी ठीक काम कर रही है, ओवेरियन हार्मोन्स ठीक हैं, ईस्ट्रोजन भी है, प्रोजेस्टेरोन भी है, पिट्यूटरी ठीक काम कर रहा है क्योंकि गोनाडोट्रोपिन्स हैं, एफएसएच है, एलएच है, के बाद भी पीरियड्स नहीं हो रहे। तो क्या रीजन है? का रीजन है क्या ये कि यूट्रस है ही नहीं, या यूट्रस है पर वजाइना नहीं है, सर्विक्स नहीं है, या यूट्रस है और सर्विक्स है, वजाइना है बट वजाइना में एक सेप्टम, something which is known as imperforate hymen or transverse vaginal septum. So all the menstrual blood which is still there in the vagina, uterus is having menstrual blood, uterus is menstruating. So this is the uterus, it is menstruating, filled with blood. This blood is going, filling up the vagina, but there is so this blood is not able to come out. This is known as either imperforate hymen or transverse vaginal septum. Or it could be a condition which we will be discussing further, known as AHMED insensitivity syndrome. Mota हमारे पास delayed puberty, which means there is a girl who is not having her periods by 15 years of age. So the causes would be something to do with the hypothalamus and pituitary. Hypothalamus और pituitary stimulate ही नहीं कर रहे हैं, ovary को तो period कैसे होंगे? This is known as hypogonadotropic hypogonadism. Hypogonadism है, which means estrogen progesterone नहीं है. But the reason is because FSH or LH ही नहीं है, gonadotropins नहीं है. So we have something which is known as hypogonadotropic hypogonadism. या फिर, coming back to the previous slide, hypothalamus or pituitary, hypothalamus and pituitary, both are okay. But some problem with the ovaries. Ovaries are not working nicely. And this is known as hypergonadotropic hypogonadism. Or we have all as well. Hypothalamus is okay, pituitary is okay, and ovaries are also okay. However, there is some anatomical problem because of which menstruation is not taking place. Alright. Now the first thing that I would like to discuss with you is hypergonadotropic hypogonadism. Why do we say hypergonadotropic? So hypogonadism because estrogen is low. Hypergonadotropic means FSH and LH is high. So when FSH and LH is present, it means pituitary is all well. It also means that hypothalamus is also all well and GnRH is also all well. So here the problem would lie with the gonad or the ovary. Why do we have hypergonadotropic hypogonadism? Is it because it's ovarian failure? ओवेरियन फेलियर क्यों हो गया? ऐसा तो नहीं कि हमने फोरेक्टमी कर दी, ओवरी निकाल दी। ऐसा तो नहीं कि हमने किसी मेलिग्नेंसी की वजह से रेडियोथेरेपी दी जिसकी वजह से ओवरी डैमेज हो गई। ना भी FSH LH आप दें, the ovaries are not going to, get stimulated. They're not going to secrete estrogen and progesterone. Or it could be just idiopathic ovarian failure. You don't know why ovarian failure ho gaya. It's just simply idiopathic. Okay. Then the cause could be Turner syndrome. So in Turner syndrome, which is XO, you have just one X chromosome. The ovaries do not work nicely. They do not work as well as normal ovaries. And they're just streak gonads. So while you can have this as a normal ovary, and in Turner syndrome, you will have just a streak ovary, just a streak gonad. An ovary which has got very little of ovarian follicles, and you'll not be able to stimulate that ovary, or in rare cases, you might be able to stimulate it off and on. And these are the patients who present to you with primary menorrhea. Then we have a condition which is known as gonadal dysgenesis. So gonad is there, but it is not working nicely. It's a dysgenetic gonad. ये एक बहुत ही डिफरेंट एंटिटी है जो मैं आपको डिटेल में बताऊंगी गोनेडल डिसजेनेसिस क्या है. So right now it is, you can understand it as gonad which is there, it's not working nicely. Dysgenesis. Two conditions होती है gonadal dysgenesis की. One is a pure gonadal dysgenesis and one is a mixed gonadal dysgenesis. Pure gonadal dysgenesis मतलब 46XX है, genetic component, however, still the gonad is not working. Another condition would be it is 46XY. Phenotypically, it is looking like a female, but actually it is 46XY, and this gonad is not working like an ovary should work because the genetic component is 46XY. So pure gonadal dysgenesis can be either 46 gonadal dysgenesis, can be 46XY dysgenesis. मिक्स क्या है? जबकि हमारे पास मिक्सचर है, कुछ क्रोमोसोम्स का 46XY है और कुछ क्रोमोसोम्स जो हैं वो 46. So it's a kind of mosaic. And all of them, what they do is that they cause problems at the level of the ovary is not functioning nicely, whether it is ovarian failure because of any reason whatsoever, whether it is Turner syndrome, whether it is gonadal dysgenesis, the ovaries are not working nicely. So despite the fact that you have lots and lots of FSH and LH, still you do not have menstruation. Okay. Let's see what is Turner syndrome. We all know that Turner syndrome is XO, or just one X chromosome which is present. And phenotypically we see short stature, the absence of secondary sexual characteristics, sparse pubic hair, webbed neck, shield-like chest, cubitus valgus. So here we see a webbed neck, shield-like chest, cubitus valgus, pigmented nevi, and other congenital anomalies. So the physical appearance of a Turner would be somewhat different from a normal individual. When you look at the genitalia, yes, the genitalia is female, but it's infantile. So the kind of appearance of mons pubis that you expect in a pubertal girl, or the labia majora, the labia minora, you don't find that much amount of development of the genitalia over here. Hypoplasia of labia minora is very common. And when you look at the ovaries, you find that they are just streak ovaries present. So, see, these are the ovaries which are present, the streak gonads. And the histopathology reveals that they are just primitive genital streaks in place of gonads. So, obviously, the ovaries are not working nicely, and there will be no menstruation. Coming on to the next condition, which is gonadal dysgenesis or impaired development of gonads. What happens is that there are some errors in cell division, or there is some alteration in the genetic material which leads to complete loss of some chromosome, some part of the gonad, or partial loss. These patients do not show stigmata of Turner syndrome, but still they have absent menarche. So, looking back at Turner, we notice, this kind of phenotype which is present. Short stature, webbed neck, a shield-like chest, vitus valgus, all those things. These will not be present in the individuals who have gonadal dysgenesis. ये देखने में बिल्कुल आपको नॉर्मल लगेंगे, क्योंकि जब आप जेनिटेलिया देखेंगे वो भी आपको ठीक लगेगा, but still there is absence of menstruation. Alright, so we discussed that either it could be 46X or it could be a 46XY. 46XY is something which is also known as Swyer syndrome, and these are the two types of gonadal dysgenesis that we see. Complete gonadal dysgenesis, also sometimes known as pure gonadal dysgenesis. So the entire genome is either 46XX or it is 46XY. Now, why does 46XY, look like a female? Okay, understood. 46XX is going to be a female, but there's some problem with the ovaries, and so they don't menstruate. Why does 46XY, pure, complete gonadal dysgenesis or Swyer syndrome, why do you expect menstruation in that individual? So, alright, when this individual was a fetus and was 46XY, at that point in time, the gonads, they failed to secrete anti-Mullerian hormone and testosterone. Because there was no anti-Mullerian hormones, Mullerian duct develops and you have because there was no testosterone, the external genitalia was female. So these individuals are thought as female, reared as female. It's only at the time of puberty when you expect them to have menstruation, they have uterus. But they will not have menstruation because they do not have ovaries. They have testes. So sometimes these individuals who have been reared as females will be brought to you by the mother that they did not attain breast development. Sometimes they will be brought by the mother that this girl did not attain menarche. And instead, what happens? So we know that the genetic component is actually testis. And instead of ovaries, which are going to release estrogen and progesterone, we have testes, which are going to secrete androgens. We have adrenal androgens. All of them combined are going to cause masculinization. So you see this diagram, this individual, the external, the phenotype of shoulders, of the chest, of the hair pattern, everything is masculine. And this is known as Swyer syndrome. When you look at the genitalia, you find that there is clitoromegaly with absence of posterior labial fusion and separate urethral and vaginal openings. So, the genitalia is also different, and the Swyer syndrome. What is important for us to know is that any type of gonadal dysgenesis with Y chromosome, so 46XY gonadal dysgenesis, because it has got Y chromosome, it has got a high risk of gonadoblastoma development. And this has the potential to undergo malignant transformation and to form a dysgerminoma. तो ये बहुत इम्पोर्टेंट है कि जब भी हमारे पास कोई एक इंडिविजुअल हो जो है फीमेल, देखने में, who has been read as female, but find out that actually the gonad is testis. It means that she has 46Y, Y chromosome है, आपने उसका phenotyping कराया, Y chromosome मिल गया. The presence of this Y chromosome means that this individual is at a high risk for having gonadoblastoma, which can get transformed to dysgerminoma at any point in time. The risk of malignancy is as high as almost 50%, almost 1 in 2. Therefore, it is very important when you diagnose this that you remove this gonad. Now we come to a condition which is known as mixed gonadal dysgenesis. So till now what we have discussed that ovaries might not function. Why? Either there is no ovary, or that ovary has been damaged because of some radiotherapy, or it is idiopathic and you don't know the cause, but the ovary is not working. And the end result would be there is no estrogen and progesterone. Or it could be that it's an individual with a Turner syndrome, short height, webbed neck, vitus valgus, segmented nevi, shield-like chest, इस तरह का एक individual है जिसके पास ovaries हैं, but they're just streak ovaries, and these ovaries will not be able to produce sufficient amount of estrogen and progesterone to cause menstruation, and the uterus will also be infantile. Or you can have an individual who has gonadal dysgenesis, which is actually a gonad which is not working nicely. 46XX hai, but that gonad is not working. So this individual is going to have a uterus, going to have a cervix, vagina, everything, and you really don't know why this gonad is not working, and you will find streak gonad. Or you can have an individual who was apparently thought of as female, but at the time of puberty undergoes virilism. So there's no menstruation, obviously. And because you have a genetic component which is a Y chromosome, this states that you please remove this gonad. Otherwise, this individual has a high risk for having gonadoblastoma, which can transform to dysgenesis. Now we come to another condition which is known as mixed gonadal dysgenesis. What exactly is this? Let's say there was an individual with a XY component when this individual was a fetus. Some of these cells continued as this XY, and some of them lost their Y component. As a result, you have a mixture of cells, some of them cis-X and some of them XY. And this individual is not going to function nicely as someone who is XY. Some of the cells would be X and some of the cells would be XY. अगर XY का component बहुत कम है और X का component ज़्यादा है, तो features more like female होंगे, और अगर XY ज़्यादा है तो features more like male. Again, this individual with mixed gonadal dysgenesis, is going to have absence of periods. Whether this individual has a Mullerian duct and a uterus, या फिर Mullerian भी persist कर गई इसमें, क्यों Mullerian persist कर गई और Wolffian भी persist कर गई? All this is going to depend upon how much is the Y chromosome और ये कितना AMH बना पा रहा है, कितना testosterone बना पा रहा है. So the presentation of these individuals really vary. Now we come to hypogonadotropic hypogonadism. What is this condition? Yes, there is hypogonadism, which means estrogen नहीं है. अगर estrogen क्यों नहीं है? क्योंकि FSH और LH ही नहीं है. क्यों नहीं है? Because there is some problem with hypothalamus, or there is some problem with pituitary. The end result is you don't have gonadotropins. And when you don't have gonadotropins, it is known as hypogonadotropic hypogonadism. The important causes: one cause is constitutional delay, one is chronic illness, malnutrition, or it could be an isolated deficiency of those neurons which are going to secrete gonadotropins, or GnRH, something which is known as Calvin syndrome. We'll discuss this in the next slide. Or it could be there's some intracranial lesion. Let's say there's a tumor which is sitting on top of the pituitary, a craniopharyngioma, or a pituitary adenoma which is not letting the pituitary and the hypothalamus function normally. So you have problem with such an LH. Just a note here, if it is constitutional delay, something which is very common, आपको कोई cause नहीं मिला, just hypothalamus or pituitary नहीं active हुए हैं, उसमें family history आपको मिलेगी, then the mother also, she had delayed puberty, and you find out that there's no problem the genetic component is all well and the female is also normal. It's just some problem with the pulsatility of GnRH. इसका इलाज है pulsatile GnRH. Start puberty. What is Kallmann syndrome? Named after Dr. Franz Kallmann. This is an endocrine disorder, and you find that there is a decrease in sex hormones. In males, testosterone कम है, females में estrogen और progesterone कम है, and there is failure to start or complete the process of puberty. Why does this happen? This happens because at the time of fetal development, so there is this area which is known as the olfactory placode, and olfactory placode पे कुछ neurons migrate करते हैं. They pierce the cribriform, and some of the neurons, they migrate from here to here. Some of the neurons, they migrate from here to here. ये neurons कौन से होते हैं? कुछ तो smell के neurons होते हैं और कुछ इसमें GnRH के neurons. So there is some problem with the development over here, and you find that these individuals, they have problems with smell also, and these individuals, they have problems with secretion of gonadotropins also. Why? Because these neurons, the GnRH releasing hormones, they, as well as these neurons of smell, the problem is somewhere over here, and both of these neurons are affected. This is known as Kallmann syndrome. Obviously, when there's problem with the GnRH secreting hormones, so GnRH will not be secreted. If GnRH is not secreted, then anterior pituitary will not be stimulated, and pituitary will not release gonadotropins. And you will have an individual, जिसका pituitary भी ठीक है, ovary भी बिल्कुल ठीक है, but that individual is not having periods. Alright. And lastly, eugonadism. So what is eugonadism? In eugonadism, eu means true. So estrogen is present, normal. FSH and LH is present, normal. And still this patient is not having periods. Why? It might be a case of Mullerian agenesis. There's no uterus. Uterus नहीं है. Uterus है तो cervix नहीं है. Cervix है तो vagina नहीं है. So obviously there'll be no periods. Or it could be that it's a case of imperforate hymen or a transverse vaginal septum. Or it could be that this is an individual which is actually a male but reared like a female, and there is no internal structure of a female. So we will be having no uterus, and the genetic component will be XY. And the reason why their external genitalia is looking like a female is because they are, let's say, insensitive to androgens. Problem with the receptor. Receptor पे sensitivity ही नहीं है androgens की. तो जो external genitalia वो सब female होंगे. But the internal genitalia remains. So this diagram is showing septum. This is transverse vaginal septum. This is showing imperforate hymen. Please note that transverse vaginal septum is present higher as compared to imperforate hymen. In either case, there'll be menstrual blood inside the uterus, inside the cervix, distending the vagina. The vagina will be distended, but there will be no menstruation. And these are the girls who will be brought to you with complaints of abdominal lump and cyclic pain. Cyclic abdominal pain. So her बार जब period होगा, obviously she'll be having periods and she'll be having pain, and this lump will increase in size. जो abdominal में lump है, because the uterus is being distended, or distend हो जाएगा uterus, but she will not be having menstruation. So you see, this is an external genitalia, and you can see there is this membrane which is present, which is known as imperforate hymen. It will result in over distension of the uterus. पर abdomen फील होने लगेगा, हेमाटोकॉल्पॉस कहते हैं. कभी कभी जब हम इसमें इंसेशन लगाते हैं इन अ न्यूबॉर्न, तो हमको म्यूकस मिलता है, which is known as म्यूकोकॉल्पॉस. और जब इसमें मेंस्ट्रुएशन स्टार्ट हो जाएगा, तो हमको फिर इसमें हेमाटोमीट्रा मिलेगा एंड हेमाटोकॉल्पस and hematometra. Let's see a few questions which have been asked on this topic. So, you have a 16-year-old girl. She has primary amenorrhea. She's never had periods. She has a normal stature. There is no breast development. FSH and LH is high. Karyotype is 46. So, is she Turner? No, she's not Turner. Why she's not Turner? Because stature ठीक है. And the karyotype is 46. Turner में 46 होगा. Is she Kallmann syndrome? Kallmann syndrome में FSH LH high is not possible because there's problem with the GnRH releasing hormones. Now, is this testicular feminizing syndrome or androgen insensitivity? Androgen insensitivity or testicular feminization में the karyotype is 46XY. She has a karyotype that's 46XX, so obviously not. Is she gonadal dysgenesis? So gonadal dysgenesis में क्या होता है? Karyotype 46XX? Yes. And still the ovaries are not working because of any reason whatsoever. FSH LH is high? Yes. Philarchy is absent? Yes, because there's no estrogen. And stature would be normal because growth hormone is normal? Yes. So, the answer is gonadal dysgenesis. Now we come to another question. So, there's a 13-year-old girl who's brought to the pediatrician with complaints of short stature and absence of milk. And on examination, her breasts are standard stage 1. What is the most common cause of a condition? Please remember, she's a 13-year-old girl. The most common cause is constipation. Alright. Now, in which of the following conditions do secondary sexual characters appear to be normal? We've been given different conditions and we've been asked about the secondary sexual characters. So, a transverse vaginal system. Will secondary sexual characters be normal? Yes, it's just an anatomic problem. Imperforate time. Will secondary sexual characters be normal? Yes, it's an anatomic problem. Weir-Rokitansky-Kuster-Hauser syndrome. Will secondary sexual characters be normal? Yes, because it's a problem with the Mullerian duct. Okay. Androgen insensitivity. Now, will secondary sexual characters be normal? So, in androgen insensitivity syndrome, the genotype is 46.5, but the external genitalia is a female, although the internal genitalia is male. Therefore, in this condition, so we've discussed transverse vaginal septum, incorporate hymen, Weir-Rokitansky-Kuster-Hauser syndrome. We've discussed androgen insensitivity syndrome. And in resistant ovary syndrome, will the secondary sexual characters be normal? Yes, they will be normal. So the answer remains 1, 3, 4, 5, and secondary sexual characters will be abnormal in androgen insensitivity syndrome. Okay. Another question. So there is a 16-year-old girl with come to your clinic. She has primary amenorrhea. What do you find? You find that height is normal, secondary sexual characters are normal. Ultrasound shows that yes, ovaries are there, but there is no uterus, and the karyotype is also 46. So, because the secondary sexual characters are normal, probably the estrogen and progesterone, they are all normal, especially the estrogen, which means 46XX should be functioning fine. Ultrasound में भी आपको ovary दिख रहा है, uterus नहीं दिख रहा है. So, it seems to be an anatomic problem, and the answer is gradient genital. Another question. This time it's a 14-year-old girl brought to you, cyclical abdominal pain, and there's a midline hypogastric lump. She has not achieved menarche yet. On examination, you find that there's a bluish bulge noted on part of the labia. What's the histology called? So, we know that this would be an imperforate hymen or a transverse vaginal system, isn't it? Because we can understand that she is having cyclical abdominal pain, uterus is bleeding inside, but that blood is not flowing inside, and that there is a midline lump, hypogastric lump. However, the reason the answer is impoveric hymen is because you can see a bluish bulge which is noted on parting the labia. And we know that impoveric hymen is at a lower level as compared to the transvaginal septum. So if you find that ये vagina आपने draw किया, transvaginal septum ऊपर होगा, impoveric hymen नीचे होगा. जब ये vagina distend हो जाएगी with a lot of blood, then आपको तरह से distended uterus or vagina दिखेगा. Hematometra, hematocolpos, and this distension. And therefore the answer is impoveric hymen. Okay. Next question. You have a 16-year-old girl who's brought to you. Complains of failure of onset of menses. Height is 150 centimeters. Breasts are underdeveloped. Sparse pubic hair is present. Ultrasound shows there is a small uterus. No gonads are visible. Which of the following statement is incorrect about the condition? So, let's see what all is there in this question. Breast underdeveloped. Estrogen nahi hai. Sparse pubic hair. Androgen nahi hai. Infantile uterus. Small gonads. And failure of onset. So, LH and FSH is going to be high. Why? Because we can see there is hypogonadism. And most probably the height is all well. So problem is lying at the level of the ovaries. And you will have high levels of LH in it. Uterus है, pregnancy हो सकती है with ovum donation. Estrogen progesterone देंगे तो उसको periods हो जाएंगे. Karyotype may have a Y chromosome. No, karyotype will not have a Y chromosome. Why? Because why? Because you are not finding any stigmata of any stigmata of it. Now, another question. There's a 16-year-old girl, primary amenorrhea. On examination, there's no breast development. Normal stature. Karyotype is 46XX. Which investigation would you perform first? Obviously, LH and FSH levels. Because you really want to know whether it is hypergonadotropic hypogonadism or it is hypogonadotropic hypogonadism. So this investigation remains the disease of choice. Right. Another question. So there is this 25-year-old lady who comes to you with complaints of 4 months of amenorrhea. FSH and LH were elevated above the normal. Thyroid is wrong. What is the next step in treatment? You've been given some choices. And the next thing that you would like to do is, what are the serum estradiol values? Thank you.